Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Today our topic is Chiari Malformations, what to know and when to worry. My guest is Dr. Paul Grabb. He's the Section Chief of Neurosurgery at Children's Mercy Kansas City. Dr. Grabb, welcome to the show.
Thank you.
So why don't we do this first for a lot of the general practitioners out there, family doctors, who maybe don't always see Chiari malformations. Why don't you first run through, what are the different types again, and what are some of the common presentations that children have with Chiari malformations?
Okay, well, first, just to define what a Chiari malformation is, just the name itself, I think, makes parents anxious and physicians anxious when they hear the word malformation. And what I try to imply is that it's not necessarily that the brain or a part of the brain is malformed in some way, but the way to think of it is that the container for that part of the brain, the cerebellum, and the brainstem that we refer to as the posterior fossa, you can think of it as the back bottom part of your skull, for some reason didn't grow large enough to accommodate the growth of the brain at that time. And so the brain itself just continues to grow. The cerebellum grows very rapidly early in infancy, and it just seeks out wherever there's room. And so if the bone itself has not grown large enough, then it just continues to grow through the hole in the base of the skull called the foramen magnum down into the spinal canal. And in essence, when that brain grows through that hole down into the spinal canal, that is what is then deemed a Chiari malformation. Now, there can be true malformations of the bone, the skull base itself, that contribute to there not being enough room, but not always. And then this leads again to the same problem of there just not being enough room for the brain there. We do categorize them into different types. Certainly the most common type that we see is a type 1, and that is where the cerebellar tonsils, which again are a part of the cerebellum, are below the foramen magnum. People argue on a definition. Most people will say that they have to be at least 3 millimeters. Some people say they have to be at least 5 millimeters down to quote-unquote be a Chiari malformation, type 1. Those that we deem type 2 are, for the sake of argument, always associated with children with myelomeningocele. That's the sort of most significant type of spina bifida. And so that's sort of its own little category on its own. And then we get fancy and have type 0s and type 1.5s, and all that does is confuse parents and confuse other physicians. And so I'll leave those definitions for argument amongst pediatric neurosurgeons at that point.
And how common are the Chiari malformations?
Well, now with really the almost unrestricted use of MRI for a child that sneezes 2 times in a row, it seems as though everyone gets an MRI at some point, and so they are quite common in the population. So the incidence is going to be in the low single digits percentage-wise. Now, the problem is that just because you quote-unquote have a Chiari malformation doesn't mean that you have a problem or are going to develop a problem. So commonly, children will present to us with the diagnosis of Chiari malformation because it was picked up on a scan that was done because they had a concussion or because they had a seizure or because they had a bad migraine headache, all of which are not related at all to the Chiari malformation. Right. Though the Chiari malformations can cause significant problems, and I categorize them into 3 broad categories for the families and for referring physicians. The first is pain, but the pain is distinctly posterior at the occipital cervical junction and midline. So in you can think of it as the back of the head at the hairline, if that's where they hurt. classically, that pain tends to be intensified by things that raise the pressure in the head, like coughing, Valsalva maneuvers, exertion, things like that. I think we pretty much are in agreement that a Chiari malformation doesn't cause frontal or bitemporal headaches. Now can the occipital posterior headache, progress and worsen to a total global headache? Yes, to answer that question. But generally, we're looking for pain where it's the back bottom part of the head. The other symptom that can occur is that can create a disturbance in the spinal fluid circulation, so that spinal fluid actually begins to cavitate and accumulate within the spinal cord. And the name for that is syringomyelia, or a syrinx formation. And it's really a slow motion injury of the spinal cord, and that can lead to a host of problems. Scoliosis, again, is the textbook presentation for a syrinx in a child with a Chiari malformation. But it can also cause motor deficits, so that the kids can come in weak. They can come in with balance and gait issues. It's not going to cause incontinence or bowel problems until they're virtually paralyzed in a wheelchair. So it would not be a kid that's not potty training is not going to be a way that a Chiari malformation or a syrinx would present. And then finally, because of the tightness in the area where it should be the craniocervical junction, the spinal cord and brainstem surrounded by spinal fluid, instead is impacted by brain tissue, and there may be in some folks, as we touched on earlier, an associated abnormality or anomaly of the actual bony craniocervical junction, whether it's the skull base or the upper cervical spine. There can be compression of the neural elements at that level, and that can create a whole host of different problems. It can be eye movement difficulties. It can be swallowing issues, to the point where children are aspirating. I've seen teenagers come in with the onset of unexplained chronic vomiting and weight loss. Again, the vomiting center for the brain is right back there. So there can be a wide range of symptoms that these kids present with.
And so as you said, right, everybody's getting MRIs today.
Mm-hmm.
We're finding the Chiari malformation more and more because of that technology. So as a physician, when do I worry? I mean, is there some guidelines that you can lay out for us that would tell me, yeah, you need to go be seen immediately, we can watch you? What are some of those guidelines?
Yeah, well, I guess, like I said, if they fall into the three broad categories of pain that we would blame on the Chiari malformation, that's a reason to seek neurosurgical consultation. And then it's a discussion of, well, how bad are you hurting? This is, are you missing school? Are you, not enjoying life because of this, or is this something that bugs you once a month and you take some ibuprofen and feel better? So pain raises a red flag. Any findings on examination, weakness, scoliosis, gait instability that would suggest a syrinx would be a reason to seek consultation, and again, we would then order further imaging of the spinal cord to look for changes in the spinal cord lower down. And then also the more alarming sort of brainstem findings of eye motion difficulties, swallowing difficulties. Again, in young children, it may be that they're aspirating, and then that could lead to asthma. So a child that is again having feeding difficulties or eye motion difficulties, swallowing difficulties are going to be a red flag to have that addressed and seen by a neurosurgeon.
What's the follow-up for a patient who's having no symptoms?
Mm-hmm. Then it's there's not much role for repeat imaging unless you're going to follow somebody that has a syrinx, has a cavitation within the spinal cord by the spinal fluid. And so really it's going to be clinical follow-up. And commonly we'll just see folks back on an annual basis, and obviously see them back sooner if any concerns develop. But it's unlikely that there's going to be some emergency or acute change. So we're comfortable following those folks annually to the point where people kind of go, hey, nothing's happening, we'll call you if we need you. And again, we customize it. There's obviously different families that are a little more anxious than others, and some want to be seen forever or seen more frequently, and so we just accommodate to that.
Okay, all right. Well, Dr. Grabb, this is fascinating information, and I want to thank you for the work that you're doing at Children's Mercy, and thank you for coming on the show today.
Sure,
you're
my
listening
pleasure.
to Transformation. Yeah, thank you. You're listening to Transformational Pediatrics with Children's Mercy, Kansas City. For more information, you go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Mike Smith. Thanks for listening.